Good evening. Welcome to tonight's launch of the Urology Channel. My name's Al-Alao, and on behalf of our entire team at Intuitive, we're so appreciative of what you, your families, and healthcare systems are doing on the front lines during this unprecedented time. As you may know, the year 2020 represents 2 decades since the first robotic prostatectomy was performed in 2000. Urologists have been leaders in robotic surgery for 20 years, and it's your pioneering work that's paved the way for countless other specialties. And the innovation continues. It's my pleasure to introduce our presenters tonight. Dr. Ketan Badani is Professor of Urology and Vice Chairman of Urology and Robotic Operations for the Mount Sinai Healthcare System. He's recognized as a world leader in the field of robotic surgery and performed well over 5,000 robotic procedures. He has a unique perspective since he's been part of this journey since the very beginning during his time at the Vaticuti Institute at Henry Ford. We're humbled to have both Dr. Badani and our CEO, Gary Guthart, on hand to give his perspective of the last 20 years and where we're headed next. So without further delay, Dr. Badani, I'll turn it over to you.
Thank you, Katie, and thank you to the entire Intuitive Surgical team for an all-hands-on-deck approach to launching the Urology Channel in what we had, which is a short period of time. A lot of work went into this, and the support's been fantastic, so thank you. COVID has disturbed all of our lives, and being in New York in the current epicenter, I can tell you that there's basically organized chaos, right? Everyone is doing their part. I mean, my department, urology, they're in the ICU, they're on the floors, they're in the ER, we're doing PPE supply chain, our staff are doing food distribution, housekeeping, everyone's doing what they can. But this is an all-consuming thing during this time, and so there are important aspects that we need to remain connected on. Obviously, family, friends, but our professional lives, our professional normalcy, which is urology and for us, robotic surgery. So I feel it's vitally important to feel normalcy in our professional life amongst colleagues, peers, and of course, medical education. So this series does not represent a lack of commitment to what is needed right now as a specialty and as healthcare professionals. So to the extent we find peace in our normal work we do, this type of activity helps me escape, if not for just a short while. I hope it will help you as well. So before we get into the didactic part of this presentation, I'm excited and truly honored to be able to introduce a very special guest tonight, Dr. Gary Guthart, who's the CEO of Intuitive Surgical and has been such since 2010, although I know that Dr. Guthart has been part of Intuitive since its inception in 1996, so he will give you a really cool perspective on things. He's an engineer by background, and so, Gary, thank you very much for being here on the Urology Channel launch.
Thanks so much for having me, and I'm happy to spend time with you and be here.
Thank you. So if we can pull up Dr. Guthart's slides, I'll let you take it away from here.
Great. Well, happy to be here. As you've said, the COVID challenge is impacting all of us, and we are likewise. Before we get into other things, I'll just share with you for a minute what we're doing and what it looks like for us. We're now at 7,000 employees. We are considered an essential business. We are in shelter-in-place locations around the world. We operate some kind of operations in a dozen countries or so, and we have some staff coming in and so on. We have implemented additional protective measures for them. We are starting to have some available manufacturing time and have started to create and distribute PPE led by the Intuitive Foundation, mainly face shields and other kinds of masks to try to do what we can, essentially a donation of our resources and our labor to try to do something for those on the front lines. We are doing our best to stabilize our employee base. We have a fantastic team. We don't want to lose them or furlough them during this period, and so we are doing our best to be productive and helpful. This isn't a time for us to worry a lot about selling. It's really about support. We are deeply connected into the Silicon Valley area and are working with and leading teams that are setting up and delivering PPE regional hospitals. It looks like we'll be able to do that across the United States. So it has changed our world too. It is absolutely not a business as usual environment. For the company, it doesn't look like this will resolve quickly, right? We're going to be working this for a couple of years, it looks like. If you haven't seen this, as a reasonable report by the former head of FDA, Scott Gottlieb, and some other thoughtful people. We have used it as a guide for us to think through our process and our behaviors and to do a little bit of planning. So we're working through that. We're clearly in phase one around slow the spread and to fill some gaps in PPE and ventilators and other things. We're working hard to do our part there to the extent that we can. I will talk a minute about surgery. I'm just going to go through this quickly. Kind of what do we do in our day jobs? Just a reminder, what are we trying to solve? I appreciate the introduction. We've been at it for some time. It's really, in our view, looking to significantly improve the quadruple aim through partnership and development with our customers, our surgeon customers and surgical teams, right? Outcomes, patient experience, care team experience, and total cost to treat per patient episode. Those are your words, not ours, but we guide our teams to them. And to do it, to deliver it, kind of easy to say and hard to do, it takes technical mastery, robotics, imaging, computing, and analytics. It takes clinical mastery, deep understanding and partnership around clinical research, educational science. We have one of the biggest and most capable human factors teams in medical device, and really cool and interesting. And then it takes operational mastery, both our operations and yours, workflows, economics, ergonomics, and standards. You all have probably seen this before. You know this about our company. You think of us, particularly in urology, as multi-port, Da Vinci Xi there, or the X. But we also have single port. Some of you are seeing more of that now. It's made its first entrance in urology. We also have natural orifice technology. That's ion system on the left. Goes into the mouth and navigates the lung in its first applications. It may have other applications in other and lumens of the body over time. So we're quite excited by it. Next slide, please. For those of you who have been with us for a while, you know this well, but for those who are a little newer, we always think about robotic-assisted surgery as the system, maybe the instruments that click on, but to actually do this well, you have to do everything. Systems, instruments, accessories, regulatory clearances, strong training programs, clinical evidence generation, sales and support teams that are highly capable, ability to market, academic society engagement and partnership and economic validation. And then it has to happen kind of procedure by procedure, country by country. It's actually a job that's never done. And so a little bit as you think about new folks coming in and wanting to do more here, we just remember a robot is just the beginning. It's necessary but not sufficient. Next slide, please. One of the things going on in the world is we're seeing a change in the way your institutions are interacting with us. And for those of you who've been with us from the very beginning, and of course, urologists really brought robotic-assisted surgery to the forefront. In the early days, the institution would take a single system, but over time, they've gone from buying one at a time to starting to outfit hospitals with 2 or 3. And this is just a chart of the number of U.S. hospitals, not ownership groups, but single facilities that have more than 5 Da Vinci systems working over time. And you've seen in the last couple of years, those are by quarter, 2019 Q1 through Q4, a strong growth. And in fact, in the last 3 years, the number of hospitals that own more than 5 or more, has grown 400% or more. You ask why? What's happening in that space? And it's really a change here, in my opinion. There are now over 21,000 peer-reviewed journal articles written by all of you and your peers on the use of Da Vinci in surgery somewhere. Several thousand level 1 and level 2 evidence. And yet we see this big change later. And what's started to happen the last couple of years is that the embedding of electronic health records and the start of integration of that data with robotic data. The Da Vinci is a great data collector. Those two things allow institutions to actually analyze their own experience. And we're seeing this happen routinely now. In the last about 18 months, 200 different hospital systems have called us and generated custom projects to look at outcomes, utilization, workflow, resource consumption of their Da Vinci systems. And what they find is that, okay, the problem with peer-reviewed journal articles is that there's always a methodology challenge, and there's always the question of, okay, well, that's good for New York, or that's good for LA, or that's good for Sweden, but it's not applicable to me in my hospital. And the difference now is with integrated data in your own environment, you can make your own decisions. And we see there that programs that have opportunities for improvement can see where they can improve. Programs that are doing well can justify to their administration the ability to expand those programs. And it's seen a real change for us. It's not just analytics that matter. We are committed deeply to ongoing clinical innovation. I'll show you some of the things we're working on, just slides and I'll conclude. I think we all know that 3D vision and precise control and articulation have been bedrock cornerstones of the kinds of things we do. Augmented reality clearly has an opportunity. The video on the left is a program called Iris. This is 510K cleared, just going through pilot sites now. Preoperative CT scan of a kidney. This is an animal model. You see a tumor on the kidney, and the ability of the surgeon at the console to take this, it's actually built by a machine learning algorithm in the cloud and then download it onto an iPad and then download it into the Da Vinci. It's all done pretty well, and you can access that image in real time when you want to look at it. You can also use it for patient consultation or preoperative imaging planning before you get in. It's pretty exciting. I showed you a picture of the ION system, the flexible catheter system. This is actually what the user interface looks like on the right. And you see a preoperative model followed by what's actually happening in the OR. It's also an augmented reality engagement. There are, I think, give or take, 15 systems now in the world, also 510K cleared. In this case, used to navigate into long. So these ideas of preoperative imaging, intraoperative imaging, real-time data fusion are not the future, they're the present, and we just need to deploy them at scale. Next slide, please. We're working on real-time imaging in other ways. This is Agent, works with a Firefly-like system, near infrared, and this is Yoder imaging. And you see white light image there, and you'll see a flash to near IR. You can see that I'm not a marketing person. You're getting the uncut engineering version. But this is going through clinical trials, and it's one of several compounds we're putting through. Works with the same concept and the same idea as Firefly, but broadens the ability. This one is Yoder imaging. Next slide, please. Simulation and remote access. This will become increasingly important over the next couple of years. Think about life after this COVID event. Clearly, digital tools and remote tools will be important. Many of you probably know this. We have been the Internet of Things and surgical robots for a decade now. Roughly a third of maintenance calls can get resolved without anybody ever having to drive anywhere because we can look into the system in real time. There are now over 4,400 surgical simulators, Da Vinci simulators out there. In the last year alone, they were used for 17,000 hours by surgeons, completing 200,000 exercises. And these also give us good insight and data as to how people learn and start to be able to give us a distribution of skills as well as a look into skill acquisition. Next slide, please. One of the things you can do with machine learning is create benchmarks that allow learning surgeons to see how they deviate from master surgeons. That's what this is. These are some technologies that are video review, but it's automatic video review done by the computer. It grades what performance looks like, and then allows the surgeon to go back and look at where did they deviate from what the master surgeon is hoping for, and gives them a score. We've gotten this validated in a couple of procedures. DVT is one. We saw a cholecystectomy in this image. We think it'll matter. It's a really hard problem. The validation is the hardest part. But I think it's fantastic. And it will also give a learning surgeon feedback as to where they live kind of in the skills curve. It's something we're really excited about. Next slide, please. Just to conclude, near term, we are clearly disrupted, and our objectives in this near term are really to listen to how we can support, pivot some of our capabilities and manufacturing resources to help frontline workers. We're doing that. How long that lasts, I don't know. Certainly, I think moving some of our manufacturing capability for the next 3 or 4 months is something we do and are doing. Ultimately, there will be a new normal. And it turns out that it kind of drives me crazy. People talk about elective procedures as if they're not important. And the reality is, yes, you have to defer elective procedures in the near term to conserve resources. But elective doesn't mean that they're not going to become necessary. And long term, our goal is clear. We want to enable a significant improvement in the quadruple aim, and those patients are going to need help. So with that, I'm delighted to count myself a part of the healthcare system, if only in a support role. I'm happy to be here with you on the call. And Dr. Badani, I'll turn it back to you.
Thank you very much, Gary. That was very insightful, and I think exactly what we just haven't had the opportunity to hear in the recent few weeks. So thank you for sharing that with us. That's exciting technology. I'm happy to open it up to some questions to the audience. We have a few minutes to do this. So if you have any questions, feel free to tap them into the chat box. The first question here is, Gary, we hear a lot about competition in the robotic space. And obviously you have a 20-year head start, but at the same time, maybe you have some insights into, intuitive thoughts on this and sort of, how this is going to play out.
Yeah, I think competition is important and it's natural. If we didn't have competitors, I'd be really nervous. It says that we're not doing something, that this isn't of value or meaning. As you said, I've been with it for a while, and from 93, I started working in robotic surgery before Intuitive was formed. Till about last year, there were about 20 commercial groups that were interested in doing something and had delivered something to the market. So there's actually more than folks think. And of those 20, Intuitive amongst them, 16 went away. They did not succeed, and 4 have remained. What does that say? It says it's possible, and it's hard. And I think that the quadruple aim that we talked about in this talk, that is the North Star for us and for others. And all of you will get a chance to evaluate what people have on offer. I haven't seen anything that is shocking to me. I think that there are some variances in the way people are thinking about architectures that will have trade-offs, and these are complex trade-offs. I can evaluate them, but you are better off evaluating them yourself and deciding, okay, why did they make the decisions they made, and does this help me achieve the objectives?
Yeah, thank you. There's a question here asking, is there anywhere we can go to learn more about the SUPR pilot study?
If you have a research interest, I am delighted to direct you to a research team and get a chance to talk to them. This is in research. It's not 510K cleared. It's not even clear to me yet exactly what the regulatory pathway is. We have a ton of interest and a lot going on there. It's really cool. So the answer is I don't really have a good public set of data for you. We can probably point you to some research ongoing and connect you to some people who are doing the work. And by the way, just reach out to Katie Al-Alao, who's on there, and we'll get her directed on our side. Thank you, Katie. And we'll get you directed to who you need to talk to.
Thank you. All right. Well, thank you so much, Gary. I think we definitely appreciate you being here with us on the Urology channel and showing showing the technology that's coming up. So we look forward to hopefully all collaborating and furthering this. But unless you have any other comments. I definitely appreciate you being here. It was awesome. Thank you.
Thank you for the invitation. And we're going to need each other for the next couple of years, so we'll work together. Take care.
Thanks a lot. Take care of yourself. Be safe.
Bye-bye.
Thank you.
All right. Well, thank you all. Again, thanks for being here. We've got a great show tonight, and a lot of people logged in. So hopefully you guys will think it's as valuable as I do. A couple of initiatives on the Urology channel before we get into the didactic. So one is the Wednesday Lunch and Learn series, and this is going to launch April 22nd. It's every Wednesday consecutively at 12:30 p.m. Eastern Time, and we'll spend an hour on different robotic topics, not just kidney, but prostate, bladder, recon, what have you. And we'll have moderators lead the sessions and panelists. And so we have close to 400 people on this call tonight. So if you're interested and you want to participate or you want to lead, I'll give you my contact information at the end. Please reach out. We'd love to have new ideas and fresh ideas. The other event is April 23rd. It's actually Thursday at the same time, 7 p.m. as this webinar tonight, focused on Da Vinci single port. And probably two of the world's most experienced SP surgeons, Dr. Kayuk and Krivallaro, are going to lead that initiative. So be sure to tune in on that if you're interested in SP and the value of that. Although this is not a CME event, I did feel like it was important to include a disclosure slide, and that is because we put a lot of effort into organizing this in the spirit of peer-to-peer education for other surgeons, residents, fellows, anybody interested. This is not for compensation. There's no honorariums, not for tonight, not for SP, and not for the weekly Lunch and Learn series. So participation is voluntary. My participation is voluntary. And I think that's important because we're all interested in doing this in the robotic community. And I just wanted to make sure we're all on the same page. So it really has been 2 decades, and I'm going to talk about building a reproducible and efficient approach for partial and radical nephrectomy with the Da Vinci SI to XI transition. So why are we launching tonight's urology channel with kidney? And there's a couple of good reasons why that might be. First, I'm going to show you some national trends in partial and radical nephrectomy. And so, although we're getting better with doing appropriate partials, we're not quite there yet. And so there's really opportunity for those of you who are interested in growing your robotic practice in the kidney space. Secondly, it is based on your feedback at a series of large CME meetings. This isn't just from the questionnaires for CME afterwards, but from just peer-to-peer discussion. There was a lot of interest in complex partial nephrectomy and the role of robotic radical nephrectomy and where that fits in. And then the last one's a little philosophical, and it's mine. And maybe it makes sense, maybe it doesn't. But when you talk about kidney cancer, the improvements in outcome is largely technical. And so robotics is a surgical platform. And kidney cancer is, by and large, a surgical disease, not taking away the role of active surveillance or ablation when it's appropriate. But if it needs treatment, it's largely a surgical disease. And so this marriage makes a lot of sense. We can actually make incremental improvements in care simply talking about technical modifications. So we all know prostate cancer dominates the robotic world. And so when you talk to anybody, obviously everyone says, well, robotic prostatectomy is the most common operation, which is true. But I will tell you, unless you actually look at the numbers, yeah, the incidence of prostate cancer is really high, but there are lots of ways to treat it. So about 85,000 robotic prostatectomies, actually I take it back, 85,000 surgeries are done. The vast majority are robotic. But kidney cancer, there are about 65,000 kidney operations done a year. And so when you actually compare the two, yes, prostate is still more, but it is not that different a number. And this is really where people can build on this, and kidney becomes a big part of people's practices if you're a robotic surgeon. This is the slide looking at partial and radical nephrectomy. And so this is from the Premier database, and it ends in the first quarter of 2019. But the top curve shows that radical nephrectomy is coming down, and this is all comers for kidney cancer, and then, again, for surgical patients. And that partial nephrectomy is going up. But we're kind of at this 40% of patients with kidney cancer get partial, and about 6 out of 10 will get a radical. And I will submit to you that that number should be double. It should be close to 80%. And I'll show you where we get that number from. And so this is where the opportunity is, and this is where we can really make an impact in the treatment of this disease, just from talking about a surgical approach. The rationale for kidney preservation, number one, obviously there's a body of evidence, and we know there's solitary kidney hyperfiltration injury. The other one, tumor recurrence on the remaining kidney, I will tell you I have a significant number of patients with solitary kidneys that I have to do a partial nephrectomy on that solitary kidney. And quite honestly, that's a stressful operation, and the risks are much higher, right? I mean, if you can't, if the tumor is central, if there are reasons why a partial is not possible, that's a huge morbidity for the patient. And now, in this era, we're seeing more and more of that because of the high incidence of radical nephrectomy in the past. And then, of course, the comorbidities associated with kidney function over time, especially in younger patients. And then secondly is the difference in survival outcomes. Now, granted, there is controversy on this topic, but I think by and large, we're seeing, outside of the one randomized trial, we're seeing the abundance of data showing that there is an advantage to partial nephrectomy from a survival standpoint. And I think nobody will argue that in the younger population, that's especially true. So what are the reasons? Okay, what are the reasons for radical nephrectomy? And this is based on a poll that was done. Okay, so number one, yes, there are large and complex tumors, and they're appropriately treated with radical nephrectomy. And again, I'm going to go back to that should be about 20%, maybe 25% of all comers in a practice or in a health system. But then there's a unique comfort with lab radical now. In general, urology as a field, and again, this isn't judgment, this is based on a questionnaire, there isn't a huge comfort with complex laparoscopy in urology as a whole. Certainly there are masters of that, and they're very good. But there's unique comfort with lap radical as an individual procedure. Then there's another big concern, and that's complications with partial. Nobody wants to have a bad outcome, and perhaps there's this fear of complications with partial. And then finally, data, perhaps you're unconvinced of the overall survival benefit. And that's fair. It's really debated widely. Although I feel like by and large, the data is pretty clear that there is. But there are factors important outside of overall survival. Right? There's patient preference, and the patient experience is a huge part of the quadruple aim, which we'll get to, for organ preservation. Patients want that. And so their satisfaction sometimes hinges on that. And then, obviously, it's convincing for partial and younger patients, and we know that. Next slide. So here's how we get to the ideal ratio of partial versus radical, right? This is my data, and it's a snapshot of the total. So it's a representation of 2017, 2018, and 2019 based on patients who consented in a research log. So it's not everyone, but it's a good representation. And what we're seeing is 77%, 75%, 76% of patients get a partial compared to a radical, all comers. And we're in a busy end-stage renal disease transplant center, so actually a lot of those patients skew this number low. So I will say that number is about 80%. 80% of patients that walk in the door should be getting a partial nephrectomy. And I'll tell you, this is reproducible also. I've talked to several of my peers outside of New York who also see that 80% is about that right number. And I think if you're dedicated, essentially if you're dedicated to robotic kidney surgery, and you're doing these partials and radicals this way, you will also find that it'll be close to 80%, 75, 82% in that range. And that's sort of how we got there. Now, there's this concept of the quadruple aim. You know, Gary Guthart talked about this a little bit, and this is important because your hospital administrators look at this. And I can send you this slide if you think it's important for your discussion with your hospital, but there are 4 categories. And I will submit that partial nephrectomy is probably the quintessential operation that aligns with quadruple aim in urology. So the first one is better outcomes, right? So you want to increase renal preservation, decrease the risk of chronic kidney disease, reduce complication rates. No question that we're able to do that with a standardized approach, and I'll show you that. Lower costs. Of course it's important because healthcare systems care about this. And when you demonstrate decreased variability from kidney operation to kidney operation, you will lower cost to the healthcare system and to the operation itself. I will show you that data. And then you're going to optimize instruments and efficiency, which also go towards lowering cost. The third bucket here is improved patient experience. We touched on that. Organ preservation, and the patients expect a low risk of complications despite that tumor complexity, and we should be able to offer that to them. But to me, the most important of all of them is the improved surgeon experience or the improved care team experience. That's not because I'm a surgeon and I care about my experience the most. It's that I actually think that this drives everything else, right? If you've streamlined and reproducibly standardized your approach to a procedure, you will improve the experience for the patient, for the OR team, for the nurses, for the hospital, and the costs. The other aspect is surgeon autonomy, right? Being able to do all of this from the console, and we've come a long way, and we're able to do that. And then finally, efficiency. So the surgeon experience actually drives everything else in the quadruple aim. So I'm going to go with a monocular aim, which is the surgeon experience. So here are three different tumor complexities. Low on the right, intermediate, and high complexity or high nephrometry score, purely endophytic and central. And I will tell you that ordinarily when we think about this, we say, well, we counsel the low nephrometry score patient differently from a complication, length of stay, readmission, and risk standpoint than we do the complex patient. But I'm going to show you that based on a standardized approach, that's actually not true anymore, that these patients all have equivalency of outcome. And by the way, the first Lunch and Learn series on the 22nd, Wednesday, we're going to have a semi-live video session going through these procedures, the tips and tricks, with a bunch of guest panelists who are also have their own standardized approaches. And so that'll be a very interesting, more technique and operative video-based session. So be sure to join in. But that's an equivalency across the spectrum. Next slide. So how has standardization improved outcomes? Can standardization improve outcomes? Yes, of course it can. That's what we're here to talk about. So what are the obstacles? The first thing I'm going to talk to you are obstacles to robotic partial and radical nephrectomy. One is confidence, right? There's a lot of surgeons who don't have the confidence to tackle anything but maybe the lowest complexity tumors in a partial scenario. But then there's consistency and setup and technique, and I'm going to show you how we've overcome that. And then the reliance, and importantly, the reliance on the bedside assistant for critical maneuvers and critical steps, and how we've overcome that. Finally, how the XI platform has really allowed us to standardize this approach, because we want to provide excellent outcomes across the tumor complexity spectrum. And that includes the setup, the port placement, instrument optimization, and the concept of FAST, which is, I'll talk about that, but it's the first assistant sparing technique, or surgeon autonomy, being able to control these things from the console and not relying on your bedside assistant for critical steps. Then I'm going to show you some very cool objective metrics on comparing Da Vinci SI to XI in my own patients. And I think you're going to find this very interesting. I did, and I didn't know what to expect. And finally, talk about robotic radical nephrectomy. And we have some very interesting comparative effectiveness data for open, lap, and robotic radical nephrectomy. So this is a slide from the 2013 robotics course at AUA on the fundamentals of robotic surgery. And this is I'm showing you this because this is, in 2013, an XI, as you may or may not know, was released in 2014. So this was a heavily SI-based course, but this was the original slide, and then this was the graphic I showed that said, okay, let's talk about how easy the port placement was for kidney surgery. But the truth is it wasn't, right? It was very complicated based on upper pole, lower pole, patient habitus. We had a lateral camera placement, port placement, which was this. There was a medial camera, and then the real struggle was the fourth arm, right? We had this, you couldn't really fit it in and make it useful, and a lot of surgeons gave up on the fourth arm and just would operate with two arms. And the fourth arm is such an important piece to the operation. The static retraction allows you to operate with two hands. And so it was really complicated. It really wasn't reproducible. The right side, same concept. There was just nothing. You had to think about this. You had to fidget, and you had to struggle. For those of you that are doing this on the essay now, you know what I'm talking about. And so this is a picture of, to me, what was an ideal port placement for SI. But as you can tell, this is hard to reproduce. The fourth arm has to figure out how to fit without hitting the hip and the other instruments. And so there was a lot of just mental cognition involved with getting this right. On the XI, that is all gone, right? So the port placement and setup on the XI system is the same. So this is the port placement, I will tell you, without exaggerating, for the last 500 kidney operations I've done, it has not changed from this. This is a linear port placement along the midclavicular line, or you can call it the lateral border of the rectus, and then one assistant port, that's a 12. On the right side, I use a static 5mm port for liver retractor, although many say they don't even need that, but I do that. And this is what I do every single time. And that's not just lower pole, upper pole. This is radical nephrectomy, IVC thrombectomy, and nephrouterectomy going down to the pelvis. This is the same. It never changes anymore. So here's a video of essentially that port placement in different views. And what you're seeing is the same orientation. Head is over here. This is ribs. The 4 ports in a linear port placement, equally separated. Now, this would be shorter in a shorter torso, longer in a longer torso, but you're just equally separating the 4 ports from each other, and then the 1 assistant port. And this is the same, every single patient. In an obese patient, it's still lateral border of rectus. In a thin patient, it's still lateral border of rectus. And this is how it is every time. So then what happens, next slide, is that the efficiency of this is astronomically improved, because from the time that we make the incision for insufflation to the time the instruments are docked is never longer than 10 minutes now, reproducibly less than 10 minutes. And we don't have to think about the port placement for each patient or the tumor characteristics for the port placement. We do it this way for all, it works for all kidney operations. And so that fidgeting factor goes away. Next slide. All right. So the other obstacle I wanted to talk to you about was the first assistant and how that was potentially a limitation to using robotics. And so here's a quote from the literature, and I'll show you a few, but you know, the role of bedside assistant cannot be underestimated. Major disadvantage, lack of surgeon control, true. And this is a limitation of the robotic approach. All of this is true. In the early days, we did rely on the bedside, or a lot of surgeons would actually scrub back in to do the bulldogs or the clamping and then scrub out. But we've, you know, with the ancillary equipment and the current technology, we've overcome this. Now, the assistant's important, don't get me wrong, and that will always be an important person. But we're taking away these critical steps and putting it back into the console surgeon's hand. And we've been thinking about this for a long time, right? This is a paper we wrote in 2012 talking about the FAST technique, which basically is saying console surgeon autonomy. How do we minimize the crucial steps that need to happen in a partial nephrectomy? Now, this was back then, and a lot has evolved and changed in the current technique. So the goals: standardize the approach, minimize the warm ischemia time, increase utilization of partial nephrectomy. The more comfortable you are, the more confidence you have, the more you're going to do it, no question. And it has to be reproducible, safe, efficient, with low complication rate. And again, maximize console surgeon autonomy. And I think we're pretty close to hitting all of these goals. So the first part is instrument optimization and orchestration. So here's a video of the instruments I use. And I will tell you, I only use, can you play the video, please? I only use 4 instruments. In the right hand, it's the monopolar scissor. In the fourth arm, it's a retractor, whether it's ProGrasp or tip up. And then the force bipolar. And if you don't know about the force bipolar, it's basically a fenestrated bipolar and a ProGrasp instrument with a foot pedal you can click back and forth between the closing strength. And it's 2 instruments in one. And so we use these 3 instruments. And then the only instrument change that happens in the entire operation is that scissor becomes a needle driver in the right hand. That's it. So 1 instrument change and 4 instruments total. And that is the optimization. Next slide. And then there's setting up of the FAST technique, or what I call the intracorporeal preparation. And so we pre-clip and pre-place all the sutures along the diaphragm. You see the clips on the tails there. We can pre-place the bulldogs, which are robotic controlled. We've already performed intraoperative ultrasound, so the ultrasound probe is inside. And so everything is ready to go, except for the role of the assistant, which now is really just exposure with the sucker. And that's really what the assistant needs to focus on, and has one task and can do it better without thinking about the rest of these steps. The rest is all ready for the console surgeon to deal with as necessary. Next slide. So here's an outcomes comparison for partial nephrectomy. And this is looking at open, lap, and robotic, this series, my series of 402 patients. And again, contemporary large open and lap series. And we basically controlled it for complexity. So if you see, these studies all look at a nephrometry score, renal score of 6. And so that was a controlling factor. I didn't want to bias the information. But you see across the board, when you have a reproducible robotic approach, all these parameters are improved, right? Ischemia time is going to be lower, and you can see that here. Operative time, it's a faster operation for all of the reasons we just talked about. EBL, yeah, it's a little bit lower. But length of stay, look at this length of stay difference between these big series. And again, you have to reproduce the post-op pathway, and that is also part of the reproducible technique. Postoperative complications, significantly lower, half of laparoscopy. And even if you look at major complications, significantly lower. Positive margin rate, lower, although there's an open series with good positive margin rates as well, but all lower than the lap series. New onset kidney disease. So this is the reason why you do a partial, right? You don't want kidney function to decline significantly after a partial nephrectomy. And so that happened in 31% of the open patients, 18% of the lap patients, 5% of these robotic patients, which means their CKD stage, their kidney cancer disease stage, got worse after surgery. This is the power of reproducibility. So this is the flow chart, and this is the way I think about it, right? You have a standardized technique. Now, I focus on FAST because that's what I use, and I can show you that it works, but it's really anything that you think works for you and can be reproducible to your team and to the patients. But any tumor complexity, low, intermediate, high, you have an equivalency of outcome. I no longer counsel the low patients differently than I counsel the high patients. They all expect a good, solid, low warm ischemia time. They all should preserve basically the majority of their kidney function. 97% of them have a length of stay less than 1 day, and should have a good oncological outcome. And so to look at that a little bit closer, here's length of stay, just to give you an example. Low, moderate, and high complexity tumors. And what you see is the vast majority have a 23-hour stay. These dots are individual patients out of 404 patients. 3, 4, and 3 that stayed longer than 23 hours. And so obviously there are reasons why patients would stay longer for legitimate reasons, but the reproducibility of this is very good. I mean, you're just talking about a handful of patients in each category, from the lowest complexity to the highest complexity. And then this is the overall comparison, low, intermediate, and high. And what you see is about 50% of these patients are low complexity, 37% are intermediate, and about 11% are high complexity tumors based on the renal nephrometry score. And yeah, there is a little bit of a difference in operative time statistically, but look at the magnitude of difference from the easiest to the hardest is about 20 minutes or 22 minutes here. So the magnitude of difference isn't great. But the ischemia time, no difference. EBL, no difference. Major complication rate, length of stay, positive margin rates, no difference. And then GFR did show a difference, but when you control for comorbidities, we don't see that difference. And I'll show you that. So here is ischemia time. You see the 95% confidence intervals overlap. There's no statistical difference from the easiest to the hardest tumors. And we'll go through these tips and tricks and the step-by-step technique at the Wednesday session. But I want to, just show the reproducibility of this. And then this is the prediction in decline in kidney function, which when controlled for comorbidities, no difference. The confidence intervals all overlap. So we are offering this sort of similarity across the spectrum, as I like to call it. Now, optimizing instrument choreography. This is interesting because it's putting dollars and cents to some of this, right? These are the disposable Da Vinci instruments that are used. Okay, so on the left side, we have what is the most common choreography for partial nephrectomy that I was given, and that is the monopolar curved scissor, the bipolar dissector, a retractor in the fourth arm, and 2 needle drivers, right? And this is $1,270 from a disposable instrument standpoint. And then what I showed you in the video, the optimized way, this was the data from last year, 4 instruments: the scissor, the bipolar, force bipolar, which is the 2 instruments in one, ProGrasp, and one large needle driver. And you see about a $200 savings per case. Now, it's not all about the disposable cost savings, because actually the efficiency of this is beyond just the cost of doing the instruments. All the other pieces of it, the operation being faster, the turnover being faster because you have a reproducible approach to things, is going to be a calculation I have not been able to make yet, but it's going to be a significant number beyond what we're seeing here. This is the comparison of SI to XI. This is my data, and what I asked is, I wanted to look at data from my program on my cases from the on-site procedural logs. So I didn't collect this data. My team, my researchers did not collect this data. This was given to me when I asked for it back by the on-site, by the team that looks at this data. This is the plug, right? The Ethernet plug you plug into the wall from Da Vinci that can tell you what's going on with the system. So I had no idea what to expect when I asked for this. Now, this is all comers. But look at the average duration in minutes from SI to XI. And again, my point here is that I'm not saying that the actual platform inherent to itself is making this difference. It's the reproducibility we're seeing with XI, especially on the kidney, and a big part of my practice is kidney. And that's why you're seeing a 20-minute difference in the actual duration of the robotic console part of the operation. When you actually look at average minutes using the instruments, which is the actual instruments moving around and not idle time, you do see a difference, but not nearly as much as the total. So this means that the actual implementation of efficiency is everything else, which is the crucial part of making an operation go quickly, efficiently, and smoothly. And then the average tool exchange count. Again, all comers, but it's about 3 instruments less per XI. And again, that goes to the 2-in-1 tools, and there's some now, and there's going to be more for this platform, but it decreases the amount of instrument exchanges. If we look at partial nephrectomy specifically, look at so when I use force bipolar or the optimized instrument I showed you in the video, it's 4.1. Now remember, I didn't collect this. This was given to me, and if I don't use it, it's basically 4.9 or 5. So it's 4 and it's 5, and it's exactly what I would think it would be. So what this is telling me is it's not just me thinking that, hey, in an ideal scenario, I'm able to do it this way. But then, yes, on certain hard tumors, we changed what we're doing, and I'm not showing you that. I'm actually showing you what they gave back to me, and every time it is for 4 instruments. The 0.1 could be an instrument broke and we had to put another one. I don't know. This is what I would consider that noise, but it's reproducibly 4 instruments for all these cases I'm doing. And then the other thing is the exchange, right? It's not just exchanging the instrument that's a big deal. It's that the ports fall out when you do that. You lose pneumo. There's a considerable amount of angst that goes into some of these issues with instrument exchanges on a kidney operation. And of course, that correlates to average instrument cost savings as well. Again, if you want any of this, reach out to me. I'll give you my contact information at the end. Okay, finally and lastly, I want to talk a little bit about radical nephrectomy. And yes, we still need this. As I said, 20-25% of our cases will be radical nephrectomy for appropriate reasons. This is the premier database, and this again represents 40% or so of all hospital admissions, looking at lap, open, and robotic. And what you see over time, and I think you'll notice this very interestingly, is they're about even. Yeah, robotics is sort of taking a foothold in sort of being more than the others, but this is the one operation actually in urology that is consistently done the 3 different ways: lap, robotic, and open. Shown another way, we see a pie chart that the distribution is about a third, and a third. So this is a good model for comparing an operation, because we don't have a lot of other surgeries that are reproducibly done all 3 ways. Or, you know, and I say reproducibly, I mean consistently done all 3 ways. The one difference between a radical and a partial is, of course, the stapling. And again, it still goes back to this concept of surgeon autonomy. So being able to control the stapler yourself but on the surgeon console takes that critical step away from the assistant. And so if you don't have a very skilled bedside assistant or a comfortable one, or you have different assistants, residents, etc., I mean, that's less of an issue now because we're controlling our stapling with the Da Vinci from the console. And remember, all the other steps, the setup, the port placement, the hilar dissection, is all the same. It is actually no different. And so then when you're doing these operations, sort of whether it's radical or partial robotic, you're just comfortable with all of these scenarios. Next slide. Thank you. So what are the common objections to robotic radical nephrectomy? And I think you'll find this interesting. So these are based on, again, CME courses and the feedback given. I don't need the robot to do a radical nephrectomy. It's too expensive. I can do it lap. Fair. All fair. I can do it faster lap. And, of course, everything comes back to it costs too much. And so this is data from my health system that was pulled. I wanted to see, and this isn't just my data, it's actually everyone in the Mount Sinai health system who's doing robotic lap or open radical nephrectomy, and kind of look at these QTI metrics. So OR time, yeah, robotic is a little longer than lap, but considerably shorter than open. Interesting, and some of this is surprising. I didn't know what to expect when I got this back. Length of stay, this was surprising. So robotic length of stay is 2 days, lap was 3 days, open was 5 days. So it's a whole day less than lap. Now, we can debate on why that might be or what the reasons are. And I don't know. This is the data. This is what's pulled. And I can hypothesize on this. And I'm happy to do that. But it's less. And then the contribution margin. So when you look at this at first glance, you would say, well, the hospital makes less money on a robot because it's a little under $14,000, whereas lap is a little over $14,000 and open's even higher. But then you got to look at that in a different way. You got to correlate that with length of stay. And I'll show you that in a second. And then there's the direct variable cost. So actually, another surprising end. The robotic operation actually costs less than a lap operation in our healthcare system. Now, maybe it's different in the Midwest. Maybe it's different in the South. But it's a start to showing that if you actually look at the receipts of your operation, imagine you just checked out and you got a charge for everything you did. Our robotic operation costs less than lap or open. And until you look at your data, sometimes these dogmas can be shattered. So let's take a closer look at this. When you look at contribution margin by day, all of a sudden the robotic operation is more profitable, right? Because it's 2 days. And so it's $6,600 per day versus $4,600 for lap versus $2,800 for open. And I challenge that you should look at this data in your own healthcare system and see if this holds true for you, because the dogma, of course, is that robotic is more expensive. But if you actually look at the receipts, surprisingly, it's not, at least in our healthcare system. So in conclusion, yes, there is a need for increased utilization of partial nephrectomy in the United States. And how we use the XI system, the ancillary equipment, the innovations, and FAST to improve those approaches, we're going to go through that step by step at our next session at our Wednesday Lunch and Learn. But standardizing the approach gives you reproducible outcomes, and that's regardless of tumor complexity. And I think I've shown you good data that if you commit to it, you will be able to achieve it. And that learning curve isn't very long. I mean, once you're facile with partial nephrectomy in a general sense, that's not a long learning curve. Surgeon autonomy. No question, this is a hugely important part of why this works. And that's good for not just the surgeon, but the assistant, the OR team, and of course for patient outcomes. And then standardizing the approach lowers the cost and improves the efficiency of the operation. And so it all is linked hand in hand. Now this slide is all of the cool symposiums we were going to have throughout the course of 2020, including having, the first sort of XI kidney case observation program here in New York. But obviously, these are either canceled or postponed. And that's really why we're able to launch the Urology channel and be able to go through this. And so the Wednesday, the purpose of the Wednesday Lunch and Learn series is to be able to perhaps continue to talk about this content with different people and different perspectives. And I submit, if you're interested in being a moderator or a panelist and you have a topic of interest, there's going to be a series of these. So we want different perspectives, not just from the academic and the highest volume people, which of course we want that perspective, but we want the private practice, the solo practice, LUGPA, you name it. The more perspectives, the better. The more interactive, the better. And this is going to be a very exciting series to be a part of. It's going to be a little bit different than what you saw tonight. We're going to have panelists you see here on the left. And so there'll be interaction. There'll be a chat box that people can live ask questions, and the moderators and panelists can answer as we're going. So there's really a spirit of collaboration on these Wednesday Lunch and Learns. And so that's my email. If you're interested in joining, please do. And then the other initiative is actually a page I took out of the General Surgery Playbook, this Facebook page called the Robotic Urology Collaborative, or RUC, where we can show in a closed forum. This will be a private group, so you have to be a healthcare professional involved with robotics. Show video clips, techniques, data analysis, and other collaborative things we can do. And it's not for patients, it's not for outsiders, it's really just for those practicing robotic surgery or interested in learning more. And the general surgeons have done a great job with theirs if you haven't seen it, but I think it's high time we do one for urology. So this will be very interesting. And with that, I'll finish my talk, and I'm happy to take some questions if we can go to the chat box.
Awesome. Dr. Badani, thank you for your presentation and sharing your insights really into how you've standardized your approach and maximized partials. So we'll open the chat box for a few questions. There's a white box at the bottom. Feel free to input those. And we will start with the first question. My hospital thinks radical should be done laparoscopically. Any advice to get to that 80% partial rate you mentioned earlier?
Yeah. This goes back to some of what I'm saying is that we want to increase the adoption of partial nephrectomy when it's appropriate, and we're just not there yet in the U.S. at least, and the Europeans have actually done a better job from that standpoint. But you need to look at your data, right? And so if you're doing lap radicals because they're appropriate for lap radical, but it costs more than a robotic radical, and you're getting more and more comfortable with the robotic partial, you will end up converting some of those radicals you think need to be radicals into partials. Again, with negative margins, with low complication rates, especially in the younger patients. And so I would really just have you look at your own outcomes and take a critical look at this, because you won't hit that 80% number until you commit to doing your operations with the approach that I do, which is I like to do a partial unless I can't or it's not appropriate. So everyone gets a partial unless it's just simply not an appropriate thing to do. The lap piece of it, mine's cheaper robotic than lap from a radical standpoint, so I'm able to make that argument. But I bet you if you look at this, you would be able to make that argument too.
Okay. Great. A lot of good questions here. Next, why do you use the fourth arm? Doesn't the assistant have 2 ports?
Good question. And so the answer is in my template that I showed you, the assistant just has 1 port, and it's one thing and it's one hand, and they only need to focus on one task at a time, which actually improves the operation for me. The fourth arm, if you're not used to using it, I will tell you is a completely game-changing scenario. It is a static retractor. It holds things under your control in a steady way, and that lets you operate with your left and your right hand and do things not one-handed, right? So if you're holding with your one hand and you're trying to dissect the hilum with the other hand, that is not nearly as good as operating with both hands. And that's what the fourth arm lets you do. And your assistant can then just focus on the one instrument and the one task they have to do. So I will tell you, you should really try to figure out how to get comfortable with the fourth arm, because your assistant will help you better. They'll be happier, and you'll be happier.
Okay, awesome. We've got so many questions here. Let's see. Great job. Do you think that the SP will help with standardization and an improvement of outcomes for partial nephrectomy, especially for a retroperitoneal approach?
Yeah, so SP, and again, we have an SP webinar that's going to happen, led by Dr. Kayuk and Crivellaro, who will address that question. I've had experience with both multi-port and single port. I will tell you that the requirement for surgeon autonomy is even higher for SP, right? On a lot of these SP techniques, you're doing your own suctioning with flexible suction. You're doing your own exposure. And the instrument that your assistant uses is so limited compared to what they're able to do for you multi-port that I think my concepts I'm talking to you about today are actually even more exaggerated with SP. Now, a reproducible retroperitoneal approach, we're going to get there. And I really hope SP is a great way to do retroperitoneal kidney surgery, which I think it is. There's some instrumentation that has to be optimized, in my opinion, and maybe the experts will disagree, but I think we're going to get there. But that autonomy piece is even more exaggerated here.
Okay, great. So we're going to take two more here, and then everyone has to join on April 22nd because there are a lot of questions. How often do you perform off-clamp partial, and if so, do you enucleate or only get a normal parenchymal margin for off-clamp partial?
Yeah, we did a huge multi-center analysis, and I'll have some of my on the 22nd of April. I will have some of my multi-center colleagues that are part of the data set on that show, and we basically showed that when you do things in a reproducible way, our ischemia times are sufficiently low that we see no difference in off clamp versus selective clamp versus main artery clamp. And so I've stopped doing off clamp because we're not seeing a renal functional outcome difference anymore. Now, that doesn't mean you can't do it. You can do it, but we're not seeing the real benefit of it. The goal is to do a partial nephrectomy, and so whether you have to do an enucleation or whether you get a margin around it is all dependent on the tumor characteristics. We know certain tumors are central or they're into the sinus, and you can't really do a partial where you get a parenchymal margin. It's a nucleoresection. And so you have to sort of decide what the best thing to do is in that scenario. If it's a purely cortical tumor, yeah, I prefer to get a partial nephrectomy with a margin on it. But that's just simply based on the geography of the tumor. Thank you.
Okay, awesome. So for those unable, this is a question from Dr. Winters. For those unable to attend the lunch session, will these be available elsewhere?
Yeah, great question. So again, you have to realize all of this is happening fluid, day to day, just like everything else we're dealing with. But what we're going to be able to do is all of these sessions, tonight's included, and all the Wednesday lunch and learns, they will be available on the WRSE website, which is the Worldwide Robotic Surgery event. They're going to be able to host them for free, and you can log in, and anyone who's interested, it's fully free and for public consumption. They can log into the website and watch these. Now, what I don't know yet, being everything happening as fast as it has, I don't know how long it's going to take for me to get the recording and then transfer it and have it live. That could be a week, that could be 2 weeks. I don't know the answer to that part yet, to be honest with you, but it will be available. Yes.
Okay. Awesome. And then your thoughts on using mannitol before and after clamping in a partial?
Yeah, I stopped completely, and I think there's a good randomized study actually out in New York that showed that it probably doesn't actually end up helping when you have low ischemia times like we talk about in robotic partial nephrectomy. So I haven't used mannitol in maybe 500, 600, 700 cases. I'm not sure. Long time. Now, if you're potentially anticipating prolonged ischemia times, and I'll show you why you wouldn't do that at the next session, because there's some good tips and tricks to just ever preventing that from happening. But of course, yeah, maybe there's a role for it, but by and large, I haven't.
Okay, awesome. Well, I just want to thank everyone. I see some great questions about stapling, use of air seal, which is going to be a topic at the first Lunch and Learn on April 22nd, incorporation of residents with your standardized technique. But thank you so much, Dr. Badani, for sharing your experience and insights this evening. And I really want to thank the